Welcome to Let's Talk Menopause's Menopause Talks with Dr. Robin Noble. And my name is Donna Klassen. I am the CEO and co-founder of Let's Talk Menopause, a national nonprofit organization changing the conversation around menopause so women and people get the information that they need and the healthcare that they deserve. Our menopause talks are central to our education efforts, and you can find the past 15 or so of them on our website. Sorry, at letstalkmenopause.org/talks. Just so people know, this is for informational purposes only and not as a substitute for professional medical advice, diagnosis, or treatment. A few housekeeping items before we get started. We've disabled the chat, but you can get information in the chat from us, including we put in there our recent updated tips on that has a lot of this information in there, and that is right now in the chat. But we encourage you to ask questions in the Q&A, and we will save the last 20 minutes or so for questions for you to ask Dr. Noble. There will also be a brief survey at the end that we will release, and we ask that you complete it so that we can continue to improve our menopause talks. So today's topic is, are you there, doctor? It's me, menopause. And we are thrilled that we are joined by Dr. Robin Noble. She is Let's Talk Menopause's chief medical advisor and a practicing gynecologist for over 20 years with a specialty in menopause. Dr. Noble completed her undergraduate work at Yale, her medical training at Columbia, and her residency and fellowship at Yale. She is a certified menopause provider through the Menopause Society, and she is board certified in menopause in lifestyle medicine. And we welcome you. She is an amazing gynecologist and colleague and friend, and we know that you're going to learn a lot from her today.
Thank you for having me. I'm happy to be here. I know this is, such a difficult time for people to navigate in their lives and find the help that they need. So any way I can answer these questions to a broader audience and maybe even help explain why it can be so challenging. So happy to be here with all of you.
Great. That's great. So an overview of what we're going to do is I'm going to ask a bunch of questions to Dr. Noble, and then we are going to, again, leave ample time for you to, turn that off, to ask questions. So let's start, Dr. Noble, with talk to us about why is it so hard, and when. I think the confusion is when to start. People don't know when to start this whole process. They're maybe they had kids and they're used to going to their gynecologist for that or their OB, and then it's sort of like this plateau and people don't know what's next. So where do people start?
And you've touched on one of the really issues of why is it so challenging? Why is it so hard? And you and I could go on and talk for hours about this, but one of the things is many people don't know when to expect symptoms and what those symptoms might be. So I think that objective of educating ourselves and being open to our changes happening is one thing that's really important. And fortunately, there's a lot more awareness now. There has been a big stigma associated with aging, associated with menopause. People often don't talk about it in their friend group, so that adds to this. But even the access in medical for medical care has been really limited since the pandemic, as well as even the education about menopause and training programs has been really minimal, not just in OB-GYN, but also in family practice and internal medicine. So there's a real problem with access issues, as well as this hasn't been an area that's been focused on in medical school and research and in training. So there are access issues, there are educational issues, and then there's the side from the patient themselves, when to ask, where to go, and how to ask those questions. I know, Donna, you and I have talked in the past that sometimes one of the best things to ask is, do you feel comfortable managing menopause? Even if this is someone in their mid-40s, that can be a really good opener for their primary care provider, may in fact feel really comfortable and have some expertise. But sometimes we need to go to other resources to find someone who has a particular interest or particular expertise. And we have links on our website, the Let's Talk Menopause website, to the Menopause Society, which tells you by zip code who's at least a member in that society, which has demonstrated some interest in the subject matter, or who's actually a certified provider and has passed a pretty, a pretty challenging certification exam. Those can be good questions. But one of the things that I think can be really helpful is just being open to and aware of changes that we're experiencing, whether that's in how we're sleeping, how our mood is, what other things might be changing around this time, even if it's palpitations, even if it's joint pain. And I think just being aware that multiple symptoms can present this way, and then we need to know how to get that help.
Right. And I think so. You bring up a couple of points. One is that maybe you don't see your OB, or maybe this is a question. What if you love your OB and you want to continue with them? Do you, or do you find just somebody who does gynecology? Like,
Yeah.
what do
I
you
think
think?
there's so much variability. I think some of the OBs are really well versed and, are very good at managing some of these symptoms. I think other ones, unfortunately, have been really focused on different areas. OB/GYN is really broad, from anything from fertility issues, pregnancy care, adolescent issues, geriatric issues. So I think many of us have a demonstrated area of interest. And if you love your OB, but this is just not something that they do or they feel comfortable with, it might be time to either have a consultation with someone else and, maybe get some information from someone else. But I think it varies so much. And I think being aware of that and being able to answer those questions and feeling empowered to say, do you feel comfortable in this area, or should I find somebody else to talk about these concerns?
Mm-hmm. Right. Because I know I've heard from a lot of people, and maybe a lot of our audience has experienced this, is they go to their OB or a provider and they say, oh, I'm having these symptoms. Could this be perimenopause or menopause? And there's, someone will say to them, oh, you're too young for that.
Mm-hmm.
What's your answer to that? What's your answer to something, when someone says that?
I run into that a lot. And actually, I think nationally there's variability whether people are seeing an OB/GYN as their annual preventative provider, whether they're seeing an internist or a family practice provider, or a nurse practitioner. NPPAs can actually be really important for providing that preventative care. But what I see is often this dichotomy of either this can't possibly be menopause, they minimize symptoms, or they will be told, well, what would you expect for a woman in this, age range, or for people in this age range, this is, really common. Or I also see the opposite, where every complaint is kind of, for lack of a better word, kind of blamed on menopause. People are complaining of weight gain and mood symptoms and sleep issues, and they might have a lot of other things going on in their lives. And some providers will kind of say, like, yeah, it's probably menopause. So some of those red flags are like, everything's menopause or nothing could be menopause. But I think if you feel you're not being listened to, you're not being heard, those are really important things to take notice and say, I really, I think we deserve better care. And I know it's really challenging. And you and I will talk about, managing expectations and when is preventative care, so it's such a time constraint when people go for a preventative visit, that if they have all these other questions, I think understanding that we might not be able to get all those things addressed at that one appointment.
Right. And I think so, just to sort of recap this, it's really important to find somebody who's, has knowledge and an interest in menopause care, to find somebody that you're comfortable with, find somebody that doesn't dismiss your concerns, but also doesn't necessarily, just say to you like, oh, that's menopause, kind of like, what do you expect? Right. So, because there are treatments and that you can feel better. And I also think that, one of the things is, symptoms of perimenopause can start 4 to 10 years prior, and you don't know when that last period is, which is what makes it so difficult, right? And so challenging.
So many scenarios where someone can have, one of the IUDs where their periods disappear and we don't have that cue, or someone could have had a hysterectomy, but they still have their ovaries. And so they don't know. So I think just being almost, hyper aware of changes that we notice, whether it's, kind of temperature regulation, whether it's sleep, whether it's mood, and just having a high index of suspicion, hey, this could be related to some of these hormonal changes. To speak about perimenopause can actually be even more challenging to manage than menopause, because there are these big peaks and troughs of hormonal symptoms and sometimes really feed anxiety, palpitations, we can see migraines, sleep disturbances. And those people can be having regular cycles. So the uninitiated can say, well, this isn't menopause, it's got to be something else because you're having regular periods. But if they don't understand that these later phases of cycles do this roller coaster, you need someone who understands the physiology, because as you say, there's so many treatment options, and they're, non-hormonal options, they're hormonal options, they're lifestyle modifications. This is really an opportunity to have a better, get a better understanding about what is happening now and how to anticipate what might happen in the next years, and a real opportunity to learn about our individual health risks and what the risks and benefits might be for these various treatment options.
Right. I think I always say that this is a time where it's a window of vulnerability and it's a window of opportunity at the same time. And I think that the approach to that, and I hope that our listeners get this, that you decide how you're going to live the next 30, 40 years of your life. And so it's really important to sort of take stock at this time and decide, what is it going to look like? How am I going to be? So let's get to how to ask questions. Go ahead.
One more thing, because I think you reminded me of something. Not only do we all have very different symptoms, but we come with different symptoms, we come with different priorities, and we come with different philosophies. And there really isn't a right answer here. And it is not a one size fits all approach. So some people can have a lot of symptoms, and if understand why, they might be willing to tolerate those symptoms, and they might be willing to kind of ride it out and say, I would rather do this my own way and naturally. And for other people, they have very different priorities, and people deserve to have that individualized approach, right? And to be acknowledged that you might have a different philosophy. And lastly, I'm a really big believer in trials, because I think, you can, if you give yourself room to say, maybe I want to try this one option, or maybe I want to try this lifestyle modification, give it a little bit of time, see if you feel better. And if, we might have to take a stepwise approach and try one thing and then try another thing. And the goal is to make you feel better within your, priorities, within your philosophy. We deserve that without judgment, really.
Right, right. And also, though, to get the facts, because I think that's also important, right? To sort of like, you always say, you do you, right? And I love that saying. But I also think it's important to say, you do you with getting the facts, right? And I think that part of it is people don't know the facts. They don't know a lot of the evidence-based information, right?
So important to know not only the evidence-based information about the treatment options, but sometimes some of the most important things are the things that people aren't aware of, like our bone health, considerations, and cardiovascular disease. And midlife is an incredibly important time in our health to understand what our personal risks might be, because the risks of a hip fracture and osteoporosis are tremendous, and people don't hear about that as much as their concerns typically about breast cancer. Same with cardiovascular disease. And now, more and more conversations surrounding dementia. And this is an opportunity to kind of look at our health risks and learn about new things, and kind of be able to anticipate what might be in our future and how we want to plan and manage that. And so finding that provider that can really be your partner, help you understand the information, figure out how you want to use the information to empower yourself to be able to live the healthiest life that we can.
It's a really, really good point. To our listeners, you lose 20% of your bone mass in those first couple of years post-menopause, and many people don't know that. And then they go and they sort of have, osteopenia or osteoporosis, and they weren't taught that. So that's, again, kind of finding the facts. Now let's just get to like how to ask questions of your provider. What should we bring up? What if it feels shameful? How do we talk about painful sex? How do we talk about urinary leaking? Some of the more shameful.
Yeah. And that's super important, because it makes me think of, the situation that sadly many of us, or some of us, have had negative experiences with healthcare in the past, and sometimes with healthcare providers. And it's tremendously important to feel comfortable with a provider and to go to a place that feels inclusive, because if we don't feel comfortable, we're not going to feel comfortable sharing some really intimate details about ourselves. And unfortunately, these details can be really important for our health and have, long-standing implications. So that is just a priority, to find a place where you feel comfortable sharing. Because you're right, it's really difficult to bring up these topics, especially if you don't feel like you're given that opportunity, number one, but you don't feel like it's a safe place. So that's something we want to, use it almost as a barometer. If you don't feel comfortable talking about these things and asking these questions, then you're not going to be getting your needs met. And we all deserve better healthcare without that judgment. So an important piece there. But I think there's better awareness in the medical community to talk about sexual function. We really need to talk about, what bothers us, right? So when someone says, what is concerning, I think following some of our symptoms for a couple months, noticing trends, what interferes with our life, and what, again, is a priority for us. But I know you wanted me to talk about preventative care versus problem-focused visits. You want me to talk about that now?
Yeah, so we can get into that. Yeah, so right, because I think that's sort of like managing expectations also of visits, right? Because I think that's another piece of it. I just to sort of backtrack a little bit, maybe Jessica, you can put in the chat the symptoms tracker, because I think that is maybe a way to track your symptoms. We have it on our website, and bring it in. If you're uncomfortable and you don't know if you're going to be able to bring up painful sex or urinary leaking, you can check it off and you can show it to them. So that's one option. But yeah, let's talk about the visits themselves. So you find a good provider, you find somebody who's trained in menopause, and just for our listeners, a regular GYN or OB you would think would be trained, but they are not necessarily trained. In the last, maybe they have 1 or 2 hours of menopause training, unless they're a menopause certified provider. And so that's where you can find it on our website. Does it mean that they're a great provider? We don't know. We just know that that means that they're menopause certified. But ask your friends, ask around who has a good provider. And I think that's always a good way to find it. So let's talk about managing expectations of your visit.
Yeah. So one of the things that I see on a day-to-day basis is really frustrating for patients and providers alike is this distinction between preventative care and kind of problem-focused visits. And a lot of people don't realize that there really are 2 different types of visits. One is preventative, and one is like, we have a concern, we have a complaint, we have a problem. And so if we go in for our regular annual preventative visit, that provider might have 17 to 30 different screening things they're going through in their head: breast cancer screening, cervical cancer screening, colon cancer screening. They're really thinking about, sunblock, sleep, alcohol, substance use, anxiety, depression. So we're trying to accomplish all these things, including vaccinations and health risks, sometimes like guns in the home. And we are thinking in a preventative way. And then if someone comes in at that point and has a whole host of symptoms, things that are bothering them, we sometimes have to say, we can't do all of this at the same visit, or we need more time, or sometimes we have to finesse it and we say, like, we can start talking about that stuff, maybe consider if there's something we want to start or investigate, but maybe we have to bring you back. And I understand the frustration to the patient, because access issues, they've been waiting a year, they have all these things built up. Even if they feel comfortable enough to unload, the provider is then like, oh my goodness, I can't possibly do preventative care well and this well when I've got another patient in my waiting room and I wasn't anticipating this. So I think if people understand that this deserves its own appointment and it deserves its own time, and if I had my druthers, I would have coverage for menopausal care and evaluation and consultation, because I think we can really make the argument that this is such an important time in our health. But I want people to understand there's a difference between preventative care and problem-focused concerns. And if you go in for your regular annual exam and you have all these other things, we can't adequately do that well. We might try, I always try, but we can't do both well.
Mm-hmm. Right. And I think that's also, I mean, I know people are just very frustrated with finding good medical care that's affordable. So I would just say, sort of, if you can, start earlier, right? Start earlier before you're having a lot of the symptoms, so you can sort of ask your questions and have a relationship and things like that. And again, that perimenopause is the time that people experience the most symptoms, especially those, or may experience, especially in that last year or 2 prior to that last period. And there are long-term health risks, so it's that keep going. So some of those symptoms resolve on their own, some of them don't.
To jump in there too, if perimenopause or these symptoms start really early, that can be a real health concern. Things starting really early is important for us to know. But what makes this such a challenging, subject is that some people have no symptoms at all. And you can have a friend and colleague that knows nothing of what you're talking, in the sense that they can transition through this and be blissfully unaware. So I think the variability makes it challenging for us to learn about what could be causing some of these symptoms, and why am I experiencing something in such a severe way, like perhaps migraines. I do think there's some, really good resources out there. Sometimes reading some books, it's almost, when we think about like what to expect when we're expecting, I think Jen Gunter's book, Menopause Manifesto, is really almost physician grade information. And for people who have recommended, like, take a look at that book, do some reading, that can really give someone a robust background of what might happen in these different organ systems. So for some people, they want to get it from books. For some people, they want to get it on webinars. But I think there's better information. And certainly we're trying that at Let's Talk Menopause, so that people can be aware of what could be related to this and what might not be. Some of these things are very multifactorial.
Mhm. Right. And
Stressful
right.
time in people's lives, right? I mean, changes, midlife transitions, empty nests, aging parents, a whole host of things that can complicate this time.
That's right. It's a more complicated time of life, and we've had a robust history, right? So that's why it also takes longer. Oh my gosh, I have so many questions before we get to the potential red flags. Actually, why don't we just get to the potential red flags
Okay.
of finding a provider? Why don't we just do that?
Okay. These are just some red flags I've come up with that I think can be helpful for people. Getting back to, if you feel minimized, if you feel like you're not being listened to or haven't been heard, if everything's kind of being blamed on menopause and nothing's really being done, if you're not offered any treatment options, because as Donna mentioned, there's so many treatment options, non-hormonal, hormonal, lifestyle modifications, cognitive behavioral therapy. So if you're not given any options, that's a concern. I think doing a whole slew of tests without much explanation, because most of the time hormone testing is not that helpful. There are times where it's thoroughly unhelpful, and at least be mindful that if someone's ordering a slew of tests, it's going to be expensive. And in most cases, it's not needed. But there are certain scenarios in kind of an earlier menopause, in those situations where someone isn't getting a regular cycle, if they've had a hysterectomy, and there are other organ systems that can be involved. Sometimes we really do need to check your thyroid and see if that can be the cause of some of these symptoms. So testing can be helpful, but a slew of testing without much kind of background or education about why that might be needed is a red flag. I think if anything's really costly and you're required to come back a zillion times, follow hormones, that's really not needed except in rare instance. Anything that's kind of a custom compounded medication, for the vast majority of people, we do not need customized compounded medications, and compounded medications are not regulated in the same way as FDA regulated options. And hormone treatment and the other non-hormonal treatments shouldn't be really expensive. So I think the expense is a concern. That's potentially a red flag. And then any provider who's selling something themselves, and if they're profiting off the way they're practicing, if they're selling supplements, if they're selling custom hormones, there are concerns about things like pellets that the Menopause Society really does not endorse, things like testosterone pellets. So if you feel that you're getting peddled anything, to me, that's a red flag. Does that help? Can you think of anything else, Donna?
No, I think that's it. I think that the compounded pharmacy, I think, is it was an important point. And then what about supplements? Because tell like, what if someone recommends supplements or things like that? What are your thoughts?
So I think supplements could be a whole nother talk. I think, again, there isn't great evidence-based information that any of these things are helpful. They have been rigorously looked at in combination with the fact that in the US, they're thoroughly unregulated. So it can potentially be really worrisome. So anybody who's recommending a lot of supplements, for the general population, I think it's a red flag. Anybody who's selling supplements, I think that's a red flag. But there are certain situations when someone's a vegan where they should be taking additional B vitamins. If someone lives in kind of the North Country, they need more vitamin D. But nothing replaces kind of a whole food, healthy diet. So I'm a big proponent of kind of real foods, but I'm also a big believer in the you do you. If you like taking certain supplements and probiotics make you feel better, just have your eyes open. Nothing should be really expensive, and there isn't great evidence that it's helpful, and it can sadly potentially be harmful.
Mhm. And with that, there's a lot of companies that have started in the last couple of years, and there's a lot of products out there. What are your thoughts on that?
Yeah, so one thing I know we wanted to touch on were kind of these online outfits for even menopausal care. And I think sadly, because of some of these access issues, um, you know, they might be one of the easiest ways for people to get help quickly and kind of the fastest and most efficient way for some people to get help and to even get a prescription. So I think some of them can be really reasonable. Some of them even take insurance. I'm still in favor of kind of a more personal, long-term approach to kind of help us manage those next decades, make sure we're getting adequate preventative healthcare screening and lifestyle modification. But for some people, that can be a real, an access point where they feel it's really hard to get help. So some of them can be really good. Just be aware that some people are making a lot of money and profiting off these things. So that was a note on the online. What was the other part of the question? Selling?
Just selling products, like selling lotions and selling cream, just all
Yeah,
that sort of stuff.
lotions and potions. There's a lot of men of profiteering, as I would say. So, have your eyes open. If you love that oil and it makes you feel good and it smells good and you're willing to pay for it, you do you, right? But I would have a hard time believing that some of these things do what they claim to do. So we have to be really careful.
Okay. And I, I had my sister-in-law had heart palpitations for years and didn't know that it was related to menopause. And she went to cardiologists and she went to other doctors and they didn't say anything. And somebody at one point said like, oh, maybe that's menopause. So
Yeah.
what are your thoughts about specialists?
Yeah, I see that a lot. And that's a good point to bring up. Remember, kind of thinking about if anything's changing around that time, we need to have a high index of suspicion that this could be related. So that's a really important point because some people will experience palpitations, migraines, skin manifestations, joint issues. So we can end up at, say, an orthopedic office or a cardiovascular, cardiologist's office or a rheumatologist. And sadly, we have to be aware that this could all be interrelated. And sometimes you don't have that primary care provider who's kind of supervising all of your care. So I think having your wits about you and asking that question, like, and sometimes we have to be persistent. Like, is there any way this could actually be related to my cycle? And the clue is, especially in the perimenopause, if you're having cyclic migraines, if you're having cyclic skin rashes, if you're having cyclic joint pain, these are hormonal until proven otherwise, right? Nothing else does that. But I think it's really important that all the specialists caring for women in midlife understand that a lot of these things can present in different ways. And even ophthalmology, I see people that say develop dry eye syndrome and they've seen ophthalmologists for years and then they finally come around to me and I'm like, and they'll ask me, if I did a trial of hormone therapy, might it go away? And sometimes it does. Same with frozen shoulder and all these other things. So have your wits about you, be your own advocate, learn about some of these things, be open to possibilities, and consider trials. The goal is to make yourself feel better with your own philosophy and your own priorities. So that would be my approach.
Mhm. And what do you say about, and maybe we're going to get into questions in a minute because we have a ton of questions. Um, but give us you sort of your like a minute overview on hormone therapy if you can, because it's coming up a lot in the chat. And I know it can't be in a minute, but talk to me just if you can, just sort of give your philosophy on hormone therapy.
So my philosophy is really about that individual person's philosophy, right? And I really encourage people to think about, what does it mean to you? Does it make sense? We are living longer and longer, and if we're going to live into our 80s and 90s and our hormones just stop around midlife, is that something that's normal? Is that something that's expected? Is that something we want to change? Interestingly, we can change that, right? You can treat some of these symptoms with hormones. So in many ways, some of these symptoms can be a choice. Many of these symptoms that are hormonally mediated can be treated with hormones, but it's a very personal decision as we get back to those individual health risks. And we're seeing, many breast cancer survivors who might not have those same options. But I think I would love to see people at least open to the idea of what's right for them and not be judged. I have some people that age beautifully on their own naturally, and they don't have these symptoms, and they don't have joint pain, and they're genetic factors that have to do with bone health, skin, hair, cardiovascular disease. So some people might want to pursue it, some people might not want to pursue it, but I think people should be given options. Does that help?
Yeah. Do people come in with their own opinions about hormone therapy? Because I know, we talk about this a lot, and Let's Talk Menopause, about the fear-based stuff around hormone therapy. Can you just share that a little bit?
I mean, I see it run the gamut. I can see people coming in absolutely wanting to leave with a prescription, and I can see people saying, absolutely, I would never want to do that. And then I can see a lot of people as they learn more about this, say bone health, and they say like, oh my goodness, I actually have a ton of osteoporosis in my family with crippling pain. And they might have been on that side of like, I never want to do hormones. And then when they understand that there's an FDA indication for hormone therapy to prevent osteoporosis, they will sometimes come around full circle and say like, I understand this differently. So I think it's about getting that information, that evidence-based information, being able to sit with it and really distill it into what does that mean for me? And there are times where sometimes people might be tolerating things pretty well. I mean, if we think back to some people who have experienced labor and we think of birth plans, sometimes people go into a hospital with a whole birth plan. I don't want this, this, and this, absolutely. And then everything changes, and all of a sudden what we really want is a healthy mother and a healthy baby, right? So I think if we're open with our ideas, we're more accepting of ourselves, of our friends, of our colleagues, that can go a long way.
Yeah.
And
Yeah.
the last thing is too, I try with my own patients to take the pressure off a little bit. You don't need to make a long-term commitment. Maybe what you need to do is treat something now, or try something now, or for a few months, or for a few years, and sometimes even for a few decades. So I think taking that pressure off, that I'm not committing, I'm not making a huge decision. I might try this. And I have many patients say who teach, for example, I'm thinking that will say, I want to do something. I might want to do hormone therapy now because I'm not sleeping at all. Once I retire or once I get through, I might want to try this on my own. That's fine too. This should be individualized, not a one size fits all. There's not a right answer here. It's about you.
Yep. You do you. Okay. So let's get to questions, because we've got a lot of them. Some of them are, we might not be able to answer some of them, but let's try. Because some of them are about treatments. And I think that's totally fine. So let's do this. Mirena IUD and perimenopause. Helpful?
Yeah, I find that can be really, really helpful. Those levonorgestrel containing IUDs really suppress that endometrial lining. So there are a couple of factors here. It really decreases the amount of bleeding that people will have. And it actually decreases the risk of endometrial cancer, which is hugely helpful. We're seeing endometrial cancer really on the rise in the US. And it can actually be a really helpful adjunct if someone wants to do a hormone regimen, because it protects that endometrial lining. So I see it enormously helpful, decreases our risk of endometrial cancer, doesn't seem to increase our risk of breast cancer. A lot of my patients have IUDs, and they can be really helpful, but it can add to the confusion, because then people don't often know when they're cycling. So there
Right,
is.
exactly. Yeah, totally. That makes a lot of sense. And so just so people know, with hormone therapy, with systemic hormone therapy, you need progesterone and estrogen if you have a uterus, estrogen only if you have had your uterus removed. This is a similar question. My question from Kansas City. For women in perimenopause who are still having cycles, is combined oral birth control the only form of HRT available to address symptoms, including low sex drive, painful intercourse? Thank you so much.
No, that's, I can certainly dive into that, and then Donna, stop me if you want me to go on. But hormonal birth control pills, or the NuvaRing, or hormonal management to kind of suppress our own endogenous cycle. So we talked about kind of these peaks and troughs when we're ovulating. If we're on something like a birth control pill, we have a super physiologic level, but it's like rock steady. So that can avoid a lot of these peaks and troughs. Migraines are a contraindication for combination hormone birth control, but it can help with a lot of those cyclic symptoms. Sometimes we'll use menopausal hormone therapy doses to just bring up the floor. So for example, if someone's suffering from migraines during their menses or during their period week, doing a low dose hormone replacement level dose is not contraindication in someone who has migraines, but it can really be helpful. And then for the vaginal symptoms of pain with sex, there are actually local vaginal options, but it's a bit complicated because birth control pills can suppress our testosterone as well. So birth control pills, perhaps in Kansas City, in that question, can actually suppress our sex drive. So it's incredibly complicated. We've got testosterone in there. We've got whether we want to suppress ovulation. We've got local symptoms. We can actually have relative vaginal dryness on birth control pills. So that could require some tweaking. But the short answer is it's not the only treatment, and it's pretty complex.
Yep. And to continue, somebody else had a question. I thought birth control over the age of 40 had a high risk of stroke, but my doctor's offering it as an option or progesterone alone. Both of those are red flags for me, but I'm not sure they should be.
Yeah, I would say not red flags. And I would say we know that oral estrogen increases that risk of clot and stroke. That's why we hear about birth control pills being contraindicated in people with, atypical migraines, smokers, people with hypertension. But that risk in people that don't have those complicating factors is really low. And as I said, it can be one of the ways to really modulate that endogenous cycle. So it's a great adjunct for managing perimenopause in the 40s. And actually the Menopause Society will also say that it's reasonable to keep people on birth control pills or equivalent. There's patch and there's a vaginal ring as well, up until even the age of 55. So it can be really helpful for people who are still cycling and experiencing cyclic symptoms. And it can be helpful for things like endometriosis and a whole bunch of other gynecologic issues we manage, like polycystic ovarian syndrome and a whole other bunch of that they're helpful for.
That's actually interesting. Somebody asked about PCOS and perimenopause. Are symptoms, so are symptoms worse if you have PCOS and perimenopause together?
Complicated, not often, but there are so many complicating factors in terms of kind of aging, our diabetes risk, weight. But with polycystic ovarian syndrome, often we're not cycling in the same way. So they might not have those cyclic symptoms, but they might see more insulin resistance. Again, birth control pills, if we can use them, can be really helpful in managing polycystic ovarian syndrome. And then protecting that endometrial lining with things like the Mirena IUD is really helpful. And I think where we see some of these newer medications, even for weight management, are going to be hugely helpful. The Ozempic and that class of medications, we're going to see this interface with really diabetes management, metabolic syndrome, polycystic ovarian syndrome, weight, and aging and midlife care. So I think, and it's statins when we talk about cardiovascular risk.
Yeah, definitely. And just to sort of say that, and because we're going to get to that, we have another question on that. It's perfect timing, but just PMDD often gets worse in perimenopause. That's sort of like, without a doubt. So,
and
so that is something
to be aware of. If I could really, get that message out, is anybody who's noticed mood symptoms around puberty, around postpartum, around their cycle, if they already have PMS symptoms, we should be acutely aware that they're at increased risk for mood and anxiety disorders around perimenopause and menopausal transition. So it should almost be, anticipatory guidance that if you've had postpartum issues, we need to be acutely aware that you're at increased risk for mood symptoms, and very manageable in a whole host of different ways.
For sure. Okay. Any experience of blood sugar dysregulation with increasing doses of transdermal estradiol, like reactive hypoglycemia, insulin hypersensitivity? Does progesterone further influence this?
So progesterone has more of a relationship. I'm not aware of a relationship with transdermal estradiol. But there's data about progesterone, oral progesterones with diabetes and insulin. Again, those progesterone or levonorgestrel IUDs are a way to protect that endometrial lining without giving us a lot of, almost minimal systemic progesterone effect.
Right. And we're learning so much more just about women in midlife with weight gain and the insulin resistance. And you're talking about these new drugs, class of drugs. And we actually have a menopause talk on that. People want to go back to that about weight gain and menopause in midlife. Okay. Next question. Why is hormone therapy not indicated for preventative care for cardiovascular and bone health, among other benefits for those who are overall low risk?
Well, it is. It should be. There is an FDA indication for the prevention of osteoporosis. So really, with that indication, you can use hormone therapy in someone with minimal symptoms just for that one endpoint. The cardiovascular risk and story is complicated from data that came out in the early 2000s in the WHI, but there's newer data that suggests if hormone therapy is started around this transition or within 10 years of that transition under the age of 60, we think there are certainly some potential cardiovascular benefits, even decreasing the risk of diabetes, metabolic syndrome. And the story about dementia is more unclear. As Donna mentioned earlier, if someone's had a hysterectomy and they need estrogen alone, it's clear that estrogen alone does have protective effects on not only bone, but cardiovascular system and actually even dementia. When we require a progesterone, again, looking at the older data, when this was typically an oral progesterone, it's a little bit more confusing about what happens with dementia. But these early starts around that transition, the data seems really encouraging that there are some beneficial effects. So in my mind, there are indications for those reasons.
So we actually have a bunch of questions here about the WHI. So, about the flaws in the study, and can you just give us sort of like another, this is gonna be hard, I know, but another just a quick overview again of the WHI study. And what happened from that is the fear of breast cancer, and we're really recovering from that, but this is 20 years later. And so can you just kind of explain it to us lay people?
I'll try to do my big Cliff Note version. So the issue with the WHI is they were actually looking at cardiovascular outcomes and stroke. And whenever we do these big scientific studies, we actually need to have it powered enough so that we see enough kind of negative outcomes. And so what they ended up looking at is older women. And we started people on hormone therapy. When I was in training in the 90s, we thought that hormone therapy was the best thing since sliced bread. And if a 65-year-old came into the clinic and wasn't on hormone therapy, we thought it was a good idea to start them. And so to start people in their 60s, mid-60s, 70s, those people who needed estrogen plus progesterone seemed to have an increased risk of clot or stroke and myocardial infarction in the first 6 to 12 months. And so there were significant negative outcomes, and they had an increased risk of breast cancer as well. And so the study got stopped, everything got kind of, I don't know, practice was completely reversed, and everybody stopped hormone therapy for about 20 years. More studies since that time have been looking at younger, healthier patients around the time of the transition, and the data is really different. There is still more concerns about combined estrogen and progesterone over a duration. So beyond about 5 years, there is a slight increased risk in breast cancer, but that risk of breast cancer that increased risk is akin to when people drink alcohol or they're overweight. It's actually a very small increased risk. Those patients that are on estrogen alone don't seem to have an increased risk of breast cancer. In fact, they have a decreased risk of breast cancer. And this message doesn't get out that it's at least neutral or negative. So estrogen alone, someone who's had a hysterectomy, is protective for bone health, cardiovascular health, likely dementia, and doesn't increase the risk of breast cancer and perhaps decreases that risk of breast cancer. So we need to get that message out so people have options for these treatment options if they so choose.
That's right. And Let's Talk Menopause is doing advocacy around this issue and getting more money for menopause research and making some of these, these treatments affordable and accessible. But that's in a nutshell. Again, we also have menopause talks about all of that, so if people can get that information. But people brought it up, and I think it's really important. Let's get to this. Is actually it's a great question. Does the symptoms tracker have options, treatments for symptoms relief? Not yet. I ask this because I will be less likely to bring up more embarrassing symptoms like incontinence or low libido if there isn't an option that I'm willing to consider. Info education is golden. So, I mean, that's something to think about. I mean, there are treatment options. So talk to us about the treatment options for incontinence and for low libido.
Yeah, I would just emphasize that there are treatment options for all of these symptoms. So there are treatment options for incontinence issues, a whole host of things. We have pelvic floor physical therapy can be enormously helpful. We have procedures, we have minimally invasive procedures, we have, minimally invasive surgeries. It all depends on the particular scenario and the type of incontinence it is. And I agree, it's incredibly embarrassing for people to bring this up, but it's incredibly important because we actually know urinary incontinence contributes to isolation because if people then are worried that they're smelling of urine. We know about this in an older population, but it's imperative that someone finds a provider they feel comfortable saying, I'm experiencing incontinence. It's incredibly common. So I think if we can help each other feel more comfortable saying, this is incredibly common. There are tons of fixes for this. We have urologists trained in this. We have pelvic floor medicine people trained in this, and we have physical therapy. So again, I don't know if we could list all the individual treatments and whether there would be treatment options that someone would be open to, but I would say I can usually find an option that people are open to. You know, talking about the problem is the biggest hurdle.
Yeah, there are two people that we work closely with, Dr. Rachel Rubin and Dr. Kelly Casperson, who are urologists, and they have websites, blogs, they're on social media, and they talk about all these options. And one of the things I do think is that this younger generation, younger than us, Robin, they're pushing us to talk about these issues. And we are. And I know we're talking about urinary incontinence. We're talking about, painful intercourse. We're talking about these things so that you won't feel as uncomfortable. And as you talk to other of your friends and peers, you realize like, oh my gosh, I'm not the only one experiencing this. So I just encourage you to own it. What's that?
Knowledge is power, right?
Yeah.
And I'm thinking of another one that sometimes comes up that my patients finally feel comfortable sharing. Sometimes just vaginal odor. That odor changes around menopause for some people. They notice it. They're aware of it. And we can explain physiologically why that's happening to people. That oftentimes the pH is elevating. The biome is actually different. This can contribute to increased risk of vaginal infections, urinary tract infections. So we can kind of explain what's happening. And there's so many treatment options for that. So even just feeling, even if you just want to write it on the paper, like what's bothering you, new vaginal odor, like sometimes we have to be reminded to, we should be, in a perfect world, we're asking all these questions. Have you noticed any changes in vaginal odor, any urinary incontinence? But even if it's more comfortable at home to just write down on your paper, these are 3 things that I've noticed that are changing. What could I do for this? Are there treatment options? And I will tell you there are treatment options for all these things.
Okay, great. This is a really important question. Why do we think perimenopause affects women of color sooner and symptoms last longer? I also would just say that we had I think we've had 2 menopause talks on this on our website. But if you want to maybe just touch on that for a little bit.
I would touch on the fact that so many of these symptoms, there are kind of ethnic differences and cultural differences too. And we do know that Black women experience worse hot flashes and for a longer period of time. And sadly, they have less good access to healthcare in the United States. And it's abysmal and unacceptable that this difference exists, but it exists. So we need to call it out. We need to acknowledge it, and we need to try to address it. So that's a little bit of how I feel about this. Why is complicated, right? There are genetic differences in some populations. We know, for example, I think in the Philippines, actually joint pain is the most common symptom of menopause, and it's not really hot flashes. And in certain Asian populations, it's very different. So we see variations, but we need to, increase our awareness to cultural differences, to our biases, to access to care, and find the providers that are well equipped to address these concerns.
Yeah. Oh my goodness, we have so many comments and questions, and I know we're not going to get all of these.
You can send them to me at some point. I love questions.
Yeah, and maybe we can answer them and send them back to people. So I'm trying to, other than HRT, is there anything that's proven to help hot flashes, particularly at night?
Loads of things.
Okay.
SSRIs, SNRIs, gabapentin, the new Veoza is the trade name, a new non-hormonal option, things that work at certain receptors in our brain. So there actually are lots of options, as well as cognitive behavioral therapy, certain lifestyle modifications, right, Donna?
Yep, absolutely. CBT really does help as well. CBT for insomnia. We have another menopause talk on that. Okay, is there a common treatment for painful sex and low libido?
I would say 2 different things, and there are common treatments for both, right? So typically, painful sex can be related to local vaginal changes, but it can also be more complex with pelvic floor dysfunction and kind of muscular issues as well. But some of those local vaginal changes that happen around menopause are very treatable with local vaginal estrogens, with actually kind of testosterone related medications, even DHEA can be helpful. So loads of treatment for changes that have happened. And even being mindful that sexual history is really important. You know, is this a new change? Is this someone who's never been sexually active before? Sometimes it takes some work with pelvic floor physical therapists with local treatment options, but that's very treatable. And people need to be aware that it can take some time, be persistent, get help. It's very manageable. Then the low libido is a whole nother question, can be very multifactorial. When people have studied it, it's very confusing to study because there are so many other issues: sleep, mood, relationship issues, hormonal issues, testosterone levels. So there are treatments for this as well. It gets a little trickier if there doesn't seem to be a clear testosterone relationship, right? And then we've looked at things like even couples yoga is one of the most successful things, believe it or not, to manage kind of, you know, perimenopausal and menopausal decreased libido. So again, not a one size fits all approach, definitely treatment options, get help, understand you're going to need to be persistent, bring an advocate if that makes you feel more comfortable, bring a partner, have these conversations. Sometimes, you know, therapists can be really helpful. Does that help?
Yeah, no, absolutely. And I think, you know, one of our listeners said that they went to somebody at a well-known Boston hospital and it was a horrible visit. I got more out of your Zoom in 15 minutes than I got from that one visit, which is really great. This is why we're doing them. What kind of training goes into NAM certification? And I think I'm just going to answer that really quickly. So it's by the Menopause Society. There is training, but that doesn't necessarily mean that they're the doctor for you or that they're a great doctor. It just means that they got additional certification and training. So I think it is really important. If you don't like your doctor, you're not, you know, go to somebody else, right? Find somebody else that listens to you, right? Would you say, Robin?
And I would say the certification is basically reading a big book, understanding a lot of minutia, and passing a test. But it's that demonstrated interest. It's someone saying, I'm really interested in this. I want to learn about this and I want the up-to-date information and stay current. So it is a good litmus test if somebody is interested and educated about this area.
Yeah. Can you talk about whether you've seen the onset of joint pain and GSM in late perimenopause in women who have been taking certain COCs, I don't know what that is, to control perimenopause symptoms for several years, like heavy periods, hormonal acne?
Yeah, so I'd have a hard time understanding that relationship because when they're doing the combination oral contraceptives, what's happening is that suppressing our ovarian function. So it's essentially just giving us hormone and we're just avoiding perimenopause. So it's kind of controlling for all those symptoms. So that would make me think that if it's new onset joint pain, it's not related. And again, it might be a more complex situation that I'm not understanding. But typically, if people are on combination oral contraceptives or that vaginal ring, it's replacing our own endogenous hormones. So we're not experiencing perimenopausal changes. We just wouldn't know. You could stay on those things forever and never have any changes. And I find that's a difficult conversation for me to sometimes have with patients. They'll come in on birth control pills and they'll have a whole host of symptoms: sleep issues, anxiety, mood changes, decreased libido, which can be related to pills, in fact, but a whole bunch of symptoms. And they'll have been told by other providers, you're in perimenopause or this is menopause. And I'll say, unfortunately, you're on pills. So we know it's not that right now. It's more complicated, right? But when we're on birth control pills or the NuvaRing, it's avoiding those physiologic changes that happen in perimenopause. So it's a way to kind of blissfully avoid perimenopause if you're a good candidate for that, and just sail into menopause and then drop down to menopause hormone therapy if someone wants to do that. So it can be very useful, but complicated.
Right, exactly. I have fibroids. Will HRT cause my fibroids to grow?
Not typically, not if it's dosed. And fibroids generally shrink in natural menopause because they get starved from those hormones. And so if you think of birth control pills at this level, think of physiologic hormone levels here, and then think of hormone therapy like much, much lower, and then natural menopause even lower than that. And so it's not going to cause them to grow. They might, in my mind, just not shrink as much. Anything that is growing in menopause is a concern for like a malignant fibroid or a concerning fibroid. So that would concern me if we saw fibroid growth on hormone therapy doses.
Mhm. And I think people don't realize that. That's why I think we're trying to change the name from hormone replacement therapy to menopause hormone therapy, because it's not a replacement of where you were. It's just lifting you up, sort of like to have a baseline level. Is
Good time to jump in there. Let me just say, Donna, too, and there are tons of doses, right? So there's not a one size fits all approach in how we manage menopause, number one, but there's not a one size fits all approach in how we manage a hormonal regimen. There are very super low doses that give us some bone protection that could be super, super low. And then there can be like a little bit higher and a little bit higher. And like sometimes we need to try and tweak that a little bit and see if someone has, you know, if their symptoms are resolved or if they're noticing bothersome new breast tenderness or headache, then that's a clue that we need to bring that down. But there are lots of different things we have in our armamentarium to customize those doses in non-compounded and even FDA regulated medications that are at your local neighborhood drugstore.
Okay. Again, I'm so sorry, everyone. We were really trying to get to everything. Hair loss and changes in hair.
Yeah, we see a lot of changes in hair and skin and bone health. The common question I get is, if I do hormone therapy, will it help? Sometimes it does. Sometimes it's more complicated. There are other treatment options for hair loss. We've actually gotten better at that recently, and it's incredibly important to people, and it can make people feel really self-conscious. So I would say, again, sometimes you really need the help of a dermatologist as well. But hair loss, we can see those changes around menopause. Sometimes hormone therapy can help. There are other stressors that can contribute, and our thyroid function is important, as well as iron levels. So that's a time where we want to do a workup. We don't want to just assume this is menopause related. We want to make sure we're looking at it judiciously, and then look at the treatment options and look for the relationships. If this all happened around menopause, it's probably menopause related. Does that make sense to people? I go back to that a lot. This all happened around this time. If this is new, have a high index of suspicion that this could be hormone related.
Yep. Okay. Can I take HRT as a postmenopausal woman for the rest of my life, if I so choose?
My answer is yes. With informed consent, you do you. I have patients in their 60s, 70s, 80s, 90s, and I just need to have those conversations every year. Do you understand that this can increase your risk of, breast cancer? The transdermal estradiols probably don't increase your risk of clot and stroke. So absolutely, I have patients that continue. And I think that question will have more research, more evidence surrounding this for these people that start around that transition that want to continue longer. And it's an important takeaway that I do remind people of. If you've started around that transition, which is the safest time to start, you can potentially continue longer as we get more data. But if someone is over 60 and sadly they didn't start and they weren't a candidate, I actually sometimes have to have those difficult conversations that those risks are probably increased for you. So if a 65-year-old says, I never got help, I never was given this information, I really, really want to start now, that's a hard conversation. I will say that with informed consent, I have started people even outside of that general 10 years under the age of 60 with informed consent. I often look at their cardiovascular risk, their lipid profile. If they're incredibly healthy and they have a very low, what we call ASCVD risk, we can look up and we can calculate our ASCVD risk, that I will still even consider at that point. But the short answer is yes, people should be empowered to do what they want to do. It shouldn't be a controlled substance. It shouldn't be a judgment. We do lots of things like use cars for transportation. People drink alcohol, use substances, smoke cigarettes, that we need to have a healthier conversation about what our choices should be.
Okay. So we're at 1:58. Maybe I'll just get to one more question. I'm so sorry if we did not answer your questions. Will specialists treat you differently if the symptoms are related to menopause? They shouldn't.
Nope.
Right.
But they should be cognizant that if you see someone who's an expert in treating menopausal symptoms, and if you ended up wanting to do hormone therapy, for example, and all those symptoms go away, problem solved.
Right, exactly. Cystic acne, I'm on HRT, recently had polyps and horrible cystic acne. Is this likely associated with menopause or HRT? Would you check my estrogen high or low?
So if the cystic acne is new and related to something new that we've done, it needs to be revisited. It's typically androgen related. So I would be, aware that, are they using any kind of androgens or testosterones? Because those are known to do that. And then it's important to know that as our estrogen level falls, our relative androgens increase. So sometimes just by virtue of our normal estrogen levels falling, we can have relative androgen changes. That's why people can notice hair around their face and kind of androgenizing activity, cystic acne. So it could be just that your own estrogen level is falling and then you have a relative increase in the androgens, or it could be if someone's increasing your androgens in some way. Does that make sense? So look for those relationships. If it's new, I would say absolutely. If it's something that we started and that happened, it's true, right? Unless you've changed your diet or something else that we don't know.
So I can't believe the time flew by. And so just for our audience, you can go to our website, letstalkmenopause.org/talks for all